This is the last talk in the session early this morning, and the topic is what's new with asthma. And when we look at medications, I don't think we have a lot of new medications for asthma, but to me one of the areas that I think that has brought a lot of attention in the last 2 years is the safety of inhaled steroids. There have been 2 or 3 studies of varying size that have looked at growth, and I want to share those with you and then kind of guide you as to where I think you need to be with your inhaled steroids and either stepping up therapy or stepping down therapy. So if you look at the outline of the talk for the next 20 minutes, we're just briefly going to talk about inflammation, matching controller therapy with severity. We'll spend several slides on that. Goals of therapy will be brief. Potential benefits of inhaled steroids I'm going to spend quite a bit of time on, and then other controller medicines I'm going to touch on briefly. I'm sure you've seen this cartoon several times over the last couple of years. As we've gone from the 80s into the 90s and now into the year 2000, we're focusing heavily on chronic inflammation, and I think the therapies that you see introduced over the next decade are going to be looking at different cytokines, different leukotriene inhibitors, anything that attacks this chronic inflammatory cascade. With asthma, we all know we have an acute irritant that can trigger bronchoconstriction, swelling, secretions. And if this irritant, whether it's a viral respiratory infection, whether it's an allergen, any of these can trigger a lot of cellular recruitment into the airway, increase cellular damage, and then set up this chronic cellular inflammation that all these anti-inflammatory medications are geared to prevent or reduce. Now, we're going to spend a couple of minutes now just kind of defining these different groups and when to initiate your anti-inflammatory therapy. And the first one is mild intermittent asthma. And the definition for mild intermittent asthma is an individual who's having symptoms less than 2 times per week, nighttime symptoms less than 2 times per month, normal pulmonary function, FEV1s of 80% predicted, 120% predicted are in the normal range, and then reduced variability in peak flow. If you look at mild persistent, the symptoms increase a little bit more. You're now having symptoms greater than 2 times per week, but less than once daily. You're having nighttime symptoms 3 to 4 times per month, typically normal lung function, and a little bit more variability in peak flow. As we go to moderate persistent, we're now up to daily symptoms, frequent nocturnal symptoms. Now lung function, if you did kind of a snapshot on a given day, they're showing mild to moderate obstruction and even more variability in their peak flow measurements. And then finally, with severe persistent asthma, these kids typically are having daily continual symptoms. They have frequent awakening at night. They have moderate to severe airway obstruction and a lot of variability in peak flow. Now, this last slide I took from Sockwriter, and I like it. And, you know, if you remember 1 or 2 things from the talk, I'd kind of remember this one because I think this one really is useful in your clinical practice. When do I start some type of chronic anti-inflammatory medication? And so I think the rules of 2, it's kind of a nice little thing to kind of file away. Yes to any of these suggests the need for chronic anti-inflammatory therapy. If your child's taking a quick relief inhaler, some type of beta agonist, more than 2 times per week, you ought to think about some type of chronic anti-inflammatory therapy. If you have a child who's waking up more than a couple of times at night with asthma symptoms, you ought to consider chronic anti-inflammatory therapy. And then finally, if you're refilling their meter dose inhaler more than their beta agonist more than a couple times a year, probably ought to look further into the history to think about starting chronic anti-inflammatory therapy. So, with that in mind, reviewing our goals always for asthma therapy, what we'd like is minimal to no symptoms during the day or night, no asthmatic attacks, minimal use of short-acting beta agonists, normal or near normal pulmonary function, and reduce any adverse effects from any medications that we initiate. Now, if you look at your anti-inflammatory therapy, I think the vast majority of the studies that you will evaluate will suggest to you that inhaled steroids, either low dose or medium dose strengths, are probably the best long-term tool that you have. And again, I think you're looking for more of those moderate to persistent asthmatics or more severe that you would initiate this therapy in. The longer you take these inhaled steroids, the less airway reactivity you see. They've looked at methacholine responsiveness in individuals started on methacholine in children. And even up into a year out, once you've initiated therapy, you can see steadily decreasing airway reactivity, which makes them less twitchy, which makes them more likely to be fine when they're exposed to challenges. However, when you stop these things, they revert back to their baseline state within 6 to 8 weeks after stopping therapy. So these things improve airway reactivity over time. It usually takes a few weeks, but you can see an increasing effect even to a year out on these medications. Benefit of inhaled steroids, reduction of symptoms, improvement in pulmonary function, reduction in bronchial airway reactivity, what we just discussed briefly, reduce of rescue medications, reductions of pulmonary exacerbations and hospitalization, and then there's some data to suggest that you may prevent chronic airway changes. In an attempt to stay within a medium to low range of an inhaled steroid, I want to reintroduce this concept of either stepping up your medication if you don't have good control on a medium strength inhaled steroid, or conversely, once you get good control, stepping down your medication to lower any potential risk for side effects. Generally, what I recommend, and I think the biggest problem I see when I when I receive referrals, is probably not being aggressive enough with your anti-inflammatory therapy. It's a lot easier for me because I usually have a 3 or 6 month history, and I can see how sick the kids have been over a long period of time. Where I think if you're on the front line, you think, oh, well, maybe this is only going to be a 2-week interval, and then all of a sudden it turns into 6 weeks, and then it's 12 weeks. I would strongly recommend to you, if you start an anti-inflammatory medication, be aggressive in what you want to start. Get them under control for a good 3 to 6 months, and then back down and see what it takes to keep them under good control. What I see is frequently not starting with a high enough dose, and then you don't achieve good control, and then the parents lose confidence. And then I get the referral when I think if you were a little bit more aggressive, I think everybody'd be more happy. So I'm going to drag you through 3 studies, and I'm going to start off with just doing a couple of brief comparisons of inhaled steroids with placebo, and then jump into the safety issue, which I think is the crux of this talk. This first study that's been published in 2000 was this CAMP study, and it's a multi-center trial. They had 3 arms of therapy, a placebo group for kids with asthma, an inhaled steroid using Budesonide, and then a third group using Nedocromil. Large numbers of kids in all 3 arms. Their primary outcome was change in FEV1, which is an indicator of medium-sized airways. And then they looked at other outcomes, secondary outcomes, rate of exacerbations, ER visits, that type of thing. The control of asthma was best in the inhaled steroid treated group. Compliance was pretty similar for all 3 groups, and methacholine responsiveness was affected by budesonide. Now, if you just look at budesonide versus placebo, what they found with the inhaled steroid treated group was there was a lowering of airway responsiveness, there were lower rates of hospitalization, lower rates of urgent care visits, lower rates for courses of prednisone, improved control of symptoms over the course of the study. It's a very good study, I thought. If you jump and you look at some of the studies where they compare inhaled steroids versus another anti-inflammatory medication, this is a leukotriene inhibitor, Montelukast, you see studies that are pretty comparable to this. This is percent of symptom-free days on the vertical axis. This is weeks in treatment from 1 out to 12 weeks. The lower bar is the leukotriene inhibitor. The upper figure is the inhaled steroid. And typically what you see in most of these studies is that you get better control in most of the studies that have been published with an inhaled steroid versus an anti-inflammatory. These tend to be more moderately ill kids with asthma, not the milder ones, but more the moderate ones. So, are they safe? Well, I think that's been a big issue for several years because we haven't had a lot of data. And so now if you look over the last 2 years, we've had 3 pretty good publications looking at this. And this is where I want to review here. First of all, potential risks for inhaled steroids, oral candidiasis, dysphonia, impaired linear growth, and this has been a big one we've been concerned about, as well as bone density, HPA axis suppression, and cataracts. First of all, I want to make this statement that there are some studies, and this one's referenced here, Archives of Disease of Children, looking at rates of growth in kids with asthma who are poorly controlled. If you look at those kids and you undertreat them, they don't grow well. Their adult stature is reduced and they're short. And so this study just bears that out, looking at kids with well-controlled asthma versus poor controlled asthma. And what you can see is those kids that are on chronic anti-inflammatory therapy tend to grow better than those kids with moderately controlled asthma or poorly controlled asthma. If you have kids that are symptomatic on a regular basis and you're undertreating them, there's a lot of data to suggest those kids don't grow well just because of their disease. So you just have to factor that in when you're looking at these safety studies on growth in kids with asthma. Okay, so here's the first of 3 studies I'm going to show you looking at growth with inhaled steroids. And the thing I want to point out is that most of these are medium strength dosing, 400 micrograms or less. 200 to 400 micrograms are kind of the low to moderate range dosing for these inhaled steroids. And the first one's using Flovent. And there are 3 groups here, the placebo group, the 50 microgram twice a day, the 100 microgram twice a day. Weeks of therapy go from 4 weeks out to 52 weeks, so essentially a year of therapy. And this is mean change in height. And what you can see is over the course of a year, all 3 of these groups superimpose on top of each other. So medium in strength inhaled steroid for a year, growth looks about the same whether you're on placebo or you're a medium strength inhaled steroid. We're going to go back to the CAMP study. Again, it was a large study. And what the CAMP study found was that the group that was treated with budesonide, they saw a significant difference on the first year of therapy. There was about a 1 centimeter less change in growth rate compared to the Nedocromil group and the placebo group. So all 3 groups grew well, but in the first year, the budesonide group was a little blunted. Not a lot, a little. But over the course of 4 years, the changes in height were pretty comparable. So let me show you that slide. So here's standing height over here, this left panel. And this is centimeters going, and my eyes are going. I think it's 150 to 160. And you can see the budesonide group, the Nedocromil group, and placebo group are all very comparable. Several years now. I think it's a 4-year study. And they were prepubescent adolescent. And this is standing height velocity, and this is 4.5 centimeters a year, 5 centimeters a year, 5.5, 6. And so this lower panel here was budesonide. And so the budesonide group in the first year was at about 5.5 centimeters per year of growth compared to the other 2. So it's about a half centimeter lower. But over the course of 4 years, they all had pretty comparable rates of growth. So the first study, the Flovent study, a 1-year study, all 3 groups look pretty comparable. You come now to a 4-year study, And you now see that, again, the groups look pretty comparable. So then I take it to the last study, and this again was a New England Journal of Medicine publication, and this one was by some Europeans. It was a prospective study, 200 kids over a 10-year period of time, 142 on budesonide, treated for a mean of 9 years, mean daily dose of 400 micrograms a day, compared to an asthmatic group with no steroid, and there were only 18 of those, and then 51 healthy siblings. What they found was that the mean differences in the measured and targeted adult heights were similar for all three groups, and their conclusion was that the inhaled steroid, given over a period of 10 years, appeared to be pretty safe and did not affect adult height. So as pediatricians and as a pediatric pulmonologist, we've been looking for some long-term data now for our inhaled steroid-treated asthmatics. And I think over the last 2 years, we're finally getting that data. And so my message to you today is that it appears if you stay at about 400 micrograms or less with your inhaled steroids, you control asthma symptoms well, and you don't appear to affect growth over a long period of time. So how do we reduce our risk for inhaled steroids? Well, one, use a spacer with our meter dose inhalers to reduce oral deposition. Have the kids rinse their mouth out or gargle after inhalation. If it's infants, I usually try to get them to drink an ounce or two of fluids. Wean to a lower dose once you get sustained control. So if you get a good 3-month period of time where symptoms are markedly improved, lower that dose. If you're at 400 micrograms a day, lower it to 200 micrograms a day. And then if you're at 400 micrograms per day and they're still having trouble, then you need to add on therapy. Oh shoot, I went the wrong way. So you have two options for adding on therapy. So if you have a moderate asthmatic who's still having symptoms, 400 micrograms per day, you're on Flovent, you're on budesonide, you're on beclomethasone, whichever inhaled steroid you prefer, you need to increase their anti-inflammatory therapy. And you either have two choices. You can either use a leukotriene inhibitor or you can use a long-acting beta agonist. The leukotriene inhibitor that we have, I think that is the easiest to use is Montelukast, and it comes in 4 milligram, 5 milligram, 10 milligram tablet size. It's very easy to administer, once a day dosing. It's a good product. The other one is a long-acting beta agonist, and here I think we're primarily looking at Salmeterol. And now with the addition of these Advair discs, it makes it very easy to couple an inhaled steroid with Salmeterol, or if you're using budesonide, I think it's very easy to add Montelukast as your second therapy. Here's a pretty typical study of what you see when you add on therapy. And this is with leukotriene modifiers, and this is weeks on therapy, and this is 2 weeks to 16 weeks, and a group of asthmatics, mean change in lung function. And what you can see with the placebo group, they get worse over time. If you use a leukotriene inhibitor alone, they have better control, but not quite as good as with an inhaled steroid alone. And yet, if you combine the two products, you probably get even better control for your moderate to severe asthmatics. So again, combination step-up therapy, it works well, and there's several papers that have similar type of data. If you want to look at your add-on therapy and compare either a long-acting beta agonist or Montelukast, there's some data that suggests that the long-acting beta agonist might be a little bit better, but I think it's pretty weak. And I show this slide too just to say that there is some data like that, but I think you're fine adding either Montelukast or Salmeterol in a combination product to improve your control if you're stepping up therapy. Both of them give you good options. So in summary, I think you need to identify children with persistent asthma and match severity to stepwise therapy. And that rule of 2 slide I gave you, I think is a good one to decide when to start chronic anti-inflammatory therapy. You need to adjust your therapy to maintain optimal control. Educate your families on proper medication delivery. You know, when we see these kids coming in on budesonide, and the parents say, oh, budesonide doesn't work. Well, you ask them how they give it, and you know the mask is out here, or they're doing one of these blow-by things, and they don't want to hold the kids down. If you're using budesonide, make sure they're using that mask and they're getting it up against the kid's face so that they're getting at least 5 to 10% deposition in the airway. If you're using Flovent and you're using a mask with the aero chamber, make sure that they hold that mask up against the kid. Whichever product you're using, make sure they're using it right, because we have a lot of problems with that. Provide written action plans for your kids, and then address any family concerns that might prevent adherence to your therapy. Thank you.